A patient reports severe abdominal pain. The immediate instinct is to provide relief. Safe nursing practice requires you to override that impulse. Gastrointestinal symptoms routinely mask life-threatening emergencies. Before administering any medication, you must apply the clinical judgment measurement model to determine if you are treating simple indigestion or impending shock. Consider a patient named Dennis. He has a documented history of peptic ulcer disease and presents to the unit complaining of what feels like severe, unrelenting heartburn. While heartburn is common, Dennis's presentation includes specific, urgent cues. Tachycardia, lightheadedness, and black tarry stools confirm an active upper GI bleed. At this moment, giving an oral antacid is actively harmful. The priority is stabilizing his hemorrhagic shock risk. Dennis must be made strictly NPO. You establish immediate IV access, prioritize his airway and circulation, and anticipate orders for an IV proton pump inhibitor to suppress acid and encourage clot formation over the bleeding ulcer. Recognizing the physiological risk of hemorrhage must completely override the instinct to administer standard oral comfort medications. The underlying pathology dictates the action. We see this exact requirement in a different presentation. A 20-year-old patient named Willow arrives with right lower quadrant pain, a low-grade fever, and nausea. She asks for a laxative because she hasn't had a bowel movement today. This triggers an absolute NCLEX safety contraindication. You never administer laxatives or enemas to a patient presenting with undiagnosed acute abdominal pain. The localized pain and fever point strongly to appendicitis. Administering a medication that forces the bowel to contract and push against an acutely inflamed appendix can cause it to rupture, turning a localized infection into fatal peritonitis. Now compare Willow to Fatima, an older adult in long-term care. She hasn't had a bowel movement in 4 days. Today, she is vomiting and experiencing intermittent cramping with a small amount of liquid stool leaking out. Liquid stool leakage combined with severe pain and vomiting separates simple constipation from a severe fecal impaction or a full bowel obstruction. The liquid is oozing around a solid mechanical blockage. Giving routine oral laxatives to Fatima will force her GI tract to violently contract against an immovable wall, worsening the obstruction. The only safe path is to withhold all oral medications and escalate the case for manual or surgical intervention. When serious physical blockages and active bleeding are ruled out, we look to pharmacological management. For gastroesophageal reflux disease and peptic ulcer disease, the primary intervention is acid suppression therapy. The fastest-acting class are the antacids. Rather than preventing the stomach from creating acid, they use alkaline bases to chemically neutralize the acid that is already present in the gastric lumen. This reference graphic breaks down the unique side effects of different antacid bases. Calcium and aluminum-based antacids routinely cause constipation. Magnesium-based antacids draw water into the gut, causing diarrhea, and require extreme caution in patients with renal impairment, as magnesium can accumulate to toxic levels. Moving down to the histamine 2 receptor antagonists, like famotidine, these actively block acid production at the receptor level. For maximum efficacy, they must be taken before meals. Patient education is crucial here. Smoking nicotine actively stimulates stomach acid production, directly canceling out the effect of the H2 blocker. The most potent class are the proton pump inhibitors, or PPRs. Medications like omeprazole bind directly to the gastric parietal cells, irreversibly blocking the final step of acid secretion. Because they are so effective, chronic use carries severe, long-term physiological consequences. Without sufficient stomach acid, the body cannot absorb vitamin B12. It decreases calcium absorption, leading to porous bones and osteoporosis. Finally, an acid-free stomach allows dangerous bacteria to survive, greatly increasing the risk of C. diff infections and pneumonia. Instead of suppressing acid, mucosal protectants like sucralfate coat the stomach lining. They form a thick, protective physical barrier over active ulcer craters. Because they require direct contact with the stomach lining to work, they must be taken strictly on an empty stomach. Another protective agent, misoprostol, replaces the gastric prostaglandins depleted by NSAID use. However, it carries a strict black box warning. It is a synthetic prostaglandin that induces uterine contractions. It will cause miscarriage or premature labor, making it absolutely contraindicated in pregnant patients. While acid suppressors provide rapid, effective pain relief, their long-term or improper administration alters baseline gut chemistry enough to cause severe, cascading systemic and infectious complications. Altering the speed of the GI tract requires the same precise calculation. For diminished motility, we begin with bulk-forming laxatives like psyllium husk, which absorb liquid to create a larger, softer stool mass. The strict safety requirement for bulk-forming agents is hydration. The powder must be mixed with a minimum of 8 ounces of water, followed by another full glass. Without sufficient liquid, the fiber forms a thick gel that can cause an immediate esophageal or intestinal obstruction. Stool softeners, like docusate sodium, act as surfactants. They are gentle, preventative agents that simply allow water to penetrate the fecal mass. They are used primarily to avoid dangerous straining in post-surgical or cardiac patients. This chart highlights the mechanism of osmotic or saline laxatives, like polyethylene glycol and lactulose. They work by actively drawing water from the surrounding tissues directly into the bowel lumen. Because they forcibly pull fluid into the gut, osmotic laxatives carry high risks for rapid, severe dehydration and dangerous electrolyte imbalances, specifically hypokalemia. Stimulant laxatives like bisacodyl and senna directly irritate the intestinal nerve plexus to force peristalsis. They carry a high risk of inducing severe abdominal cramping. Chronic use causes the colon to lose its natural tone, creating a permanent physiological dependency to achieve a bowel movement. The golden rule of motility agents remains absolute. Regardless of the laxative class, the nurse must completely rule out an anatomical bowel obstruction or acute inflammation before administration. When managing hypermotility, the core safety rule is simple. You never artificially suppress diarrhea if the underlying cause is an infectious toxin, like C. diff or dysentery. Paralyzing the gut traps the multiplying pathogen inside the body, leading to tissue damage, sepsis, and a deadly dilation known as toxic megacolon. For safe, non-infectious diarrhea, loperamide is an opioid agonist that slows the gut locally without crossing the blood-brain barrier. However, prescription agents like diphenoxylate combined with atropine work systemically, carrying much higher risks of central nervous system depression, extreme drowsiness, and anticholinergic toxicity. Bismuth subsalicylate is available over the counter and effectively reduces inflammation. It causes a harmless but alarming side effect, turning the tongue and stool black. Because it contains salicylates, giving it to children or teenagers with viral illnesses introduces a severe risk of Reye syndrome. Under GI stimulants, we find prokinetics like metoclopramide. These agents force upper GI motility, emptying the stomach faster for conditions like diabetic gastroparesis. But by blocking dopamine receptors, they introduce severe neurological risks, including debilitating extrapyramidal symptoms and irreversible tardive dyskinesia. Altering the speed of the GI tract always trades one problem for another. You are either risking the entrapment of dangerous pathogens inside the body or risking severe neurological side effects to force the system to move. When GI distress results in severe nausea and vomiting, antiemetics are our primary pharmacological defense. But choosing the right agent depends entirely on the patient's baseline vulnerabilities. 5-HT3 antagonists, like ondansetron, are highly effective and relatively non-drowsy, making them the standard first-line choice for general postoperative or chemotherapy-induced nausea. However, ondansetron carries a critical cardiac risk. It can prolong the QT interval. In patients with existing cardiac disease or electrolyte imbalances, this can trigger fatal arrhythmias. Dopamine antagonists, like promethazine, operate with an entirely different risk profile. They effectively shut down the vomiting center in the brain, but induce heavy, debilitating sedation and pose a severe risk for respiratory depression. Intravenous promethazine requires strict administration protocols. It is a known tissue vesicant that will destroy veins if not heavily diluted. Furthermore, the extreme sedation makes it a massive fall risk, and it is strictly contraindicated in children under 2 due to the risk of fatal respiratory arrest. Resolving nausea is rarely without consequence. You must continually weigh the immediate benefit of an antiemetic against the introduction of significant cardiac or neurological vulnerabilities. In any acute GI presentation featuring severe vomiting or diarrhea, Medication is only half the equation. Restoring the patient's fluid volume deficit must happen simultaneously with or prior to administering symptom relief. The clinical cues for immediate intravenous fluid intervention are clear: sustained tachycardia, systemic hypotension, and severely dry mucous membranes. If the circulatory volume is collapsing, a pill will not save them. In the outpatient setting, we have to dismantle a dangerous assumption. Patients look at retail shelves and equate over-the-counter with risk-free. Education regarding OTC acid reducers must be strict. Patients must follow exact dosing guidelines. They should never mix multiple classes of acid reducers without physician oversight, and they must strictly space antacids at least 2 hours apart from their other prescription medications to prevent severe absorption failures. This extends to natural vitamins and supplements. You must directly interrogate patients about their supplement use. Many assume herbal remedies aren't worth mentioning, hiding dangerous drug interactions from the medical team until it's too late. Proactive patient education regarding strict medication limits, contraindications, and baseline hydration is the ultimate preventative measure against self-induced pharmacological harm. Safe GI pharmacology requires a commitment to treating the underlying clinical pathology, not blindly silencing the surface symptoms. This requires strict adherence to the clinical judgment measurement model. You must assess the patient for physiological red flags, like hemorrhage, obstruction, or systemic infection, before reaching for a pill. Supposedly common medications, from retail antacids to prescribed laxatives, alter systemic absorption, force mechanical organ contraction, and depress the central nervous system. They command the exact same respect as high-alert medications. GI safety depends on the nurse recognizing the moment to stop. Withholding an oral medication when cues point to an obstruction or bleed is the final safeguard against pharmacological harm.